Yeah, this is my clinic in Dortmund. If you are interested, you could go to our website, niliusclinic.com, and see some videos and some maybe interesting things. Maybe you can visit our clinic when you're here in Germany. Sometimes we do some courses. And the conflict of interest is that the current studies are osteocentral anesthesia, allografts, or especially 3D bone builder technology. Clinical studies with tapered implants with the University of Krems in Austria. We have some outcome analysis about 10 to 15 years now, follow up SICAs, SIC Max, Straumann, and Nobel Biocare. And for facioplastic surgery, investigate the long-term stability after different forms of genioplasty. Your expectation today, the horizon, I want to show you 10 case reports. I want to talk about 30 hours patient education. This is very, very, very important in Germany. And we talk about the reflection of 3 judicial processes, litigation. Sometimes it's bad, especially in Germany or in Europe and in the States as well, when you see there are some people complaining and you have to explain what you have done or what you have educated about. Out of this, of the case report and patient education, to sum it up, the experience, I will give some consequences that is very important for my daily work. And this is a so-called chronological workflow that helps you to make sure that you do not forget anything in treatment. I will end up with 2 flow charts as a decision support for you when you decide, do you do augmentation or not? And I will do a reflection, think over of the most common mistakes I've made in my small career here. So when we talk about implantology, this small screen, we talk about 0 to 6 months. 0 months means immediate loading of an implant, and 6 months means bad bone quality, and you let the implant heal into the bone. And I will show you one case. This is a very easy case. When we talk about complications in this small field of implantology, we have pre-operative complications, meaning planning. We have intraoperative complications when you hurt some anatomical structures, and we have post-operative complications. We have prosthetic complications, and we will finally have problems with the patient when you do not have the correct communication. So this is a very easy case I made in 2018. There's a young lady, about 19 years old. One of the lower right molar was not there. It was a genetic maybe, and I put an implant, was not that big, and I hurt the nerve. When you have a little look here in this area, you can see I got directly into the bone. It was easy for me for implantation, but finally I had to remove the implant. Normally I talk to my patient, I say, look, when the sensibility is not there this evening, give me a call, and you come to me very urgent the next day. So we had to remove or slightly put the implant in another position. And this is the prosthetic on the shorter implant. The axis is, I think it's quite good, but anyhow, it was not judged. But when this is judged in Germany and you show your pictures, your x-rays, you have normally 5,000 euro penalty. And this is typical. What says Confucius, Master Kong in China, he says, if you make a mistake and do not correct it, this is called a mistake. So make sure that you have good contact to the patient, that they give you a call back, and then you can be sure that it is in the right way. The second case is also an intraoperative complication. Also, in 2018, I thought, what extendedly can you do to avoid all mistakes? Sorry for the G there. So we tried to avoid all complications in this special case. You can see there. This is also a young lady. At that time, she was pregnant, 7th month, and so we had to wait. And this is a situation you can see. This is a central incisor with an apical part. I can show you here. Let me see. I have different screens here. This is one of the root filling material, and also one apical granuloma on the left lateral incisor. This is a DVT, the sagittal split. And now this is the workflow to avoid any mistakes. First of all, you have your digital DICOM data, DVT in this case. Then we made an intraoral scan. Number 2. For that, you need the software. Diagnostic planning tool. Then you have to plan how it works for the template. You have to design a model with a digital analog. You need the prosthetic restoration when you start with the operation. We tried to do this immediate loading on implantation after extraction. You need a printing guide, a model, a template there, as you can see at number 10, and the in vitro guided surgery and restoration. And finally, you end up with the smile of a patient. Situation again, DVT scan. This is from a submental vertical view. This is the situation. And now the big question is, and there's a gap, you can use, finally, this is the situation. I have different screens here. This is the situation also with soft tissue covered. And this again. And now you, as an implantologist, have to decide what is the right implant for this situation. Sometimes this is very difficult. For example, we used the SIC implant system. As you can see above, we were supported by SIC in this case. Henry Schein helped us with navigation, the dental lab from Europol, and finally the operation was done in our clinic. So this is a slightly tapered implant form, parallel, maybe this one. Or what about the diameter or the length? 4.7. Sometimes it's very hard to have a very big implant in the front. You see the buccal side here is not that big. Here you can see it. Or it's better to make an implant with a lower or with a reduced diameter, 4.2 millimeters. I love this 4.2 in the front. Or you go by 4.2 into different design, ACE design, max design, maxillary implant, longer, maybe 13 millimeters. Keep in mind, there is also the material here in the apical part. And what do you do with the apical part? This is sometimes a question you have to talk to your patient. Or you have a very extended, a very long implant. Or SIC max 13 millimeters or a tapered form. We finally wanted or tried to have the SIC tapered form, because slightly tapered is not that aggressive and you have a very good grip here in the apical part with the implant. And you have a lot of space here where you can put some artificial bone, bovine, for example, to have a good buccal side of the implant. So this was, after making all these decisions, our final solution to go with this implant. 4.2 millimeters, 30 millimeters length. And this is the digital workflow planning by Henry Schein in Germany, Prosthetic. Everybody who is used with navigational templates know this. Then we printed this. We made the model planning, and it finally ended up with an artificial model. At that time, the patient came only one time for radiological investigation and for the intraoral scan. We had no plaster, we had nothing. We had only 2 scans. Einmal the X-ray scan, the DVT, and the intraoral scan with 3 shade. So then the printing of the template and the model. And then to avoid every mistake, we try to have this operation done before to show how precise is the model, how precise is the template, and how is it possible to insert the implant in the correct axis. After doing this, we have the implant in position and the prosthetic crown as an immediate loading. And after doing the real operation, we compare these both operation, the in vitro operation and the in vivo operation, and we showed that they are very accurate. So we did this. This is a special planning tool. Make sure that your template is directly onto the teeth. And this is to make sure that there is no problem in the vertical or in the height when you insert it. Then you have the reamer. Sometimes it is a very hard plaster. This is of artificial material. Then you have the drilling sequence. I will make it short. It's not that big. It's very well, only maybe 6, 1, 2, 3, 4, 5, 6 different instruments. Here the implant. Yes, you can see tapered screwed implant. You insert it. And finally, the big moment, does it work with the prosthetics? These are the digital implant mounts to make a control. And then the final moment, put in the implant, load it, and you can see it works quite good. Even in a way that you can use a screwed frontal implant. Sometimes it's quite hard to have a real access, but in this case, it is possible to do a navigational implantation, supported, CAD/CAM supported, and then you come up in an ideal way. But this is in vitro operation. And the next, this is a patient. You can see the young lady in the middle and the team. Now she's laughing because it's before the operation, and now the operation starts. This is the clinical view. This is the tray from SIC, the navigational tray, and you can see in the lower right the template. We started to make the root resection of the lateral incisor on the left side first, and after doing this with a piezotome, we removed the root and of this that rested also in position 1-1. And after doing this, I recommend making also a small cut for a root resection because of the material that is in the apical part. This is the root filling material, what we have seen at the DVT before. And I definitely recommend, you cannot get it out. Sometimes it's laid under the periosteum, but sometimes it's also in the bone, and you cannot make sure that you remove all of the things. I know there are people say, well, I grab it with some carets, it is possible. But for me, especially in this case, I wanted to make sure that no artificial material is on the apex of the implant. And that is sometimes very special. You can see when you do the implantation where the tip of your drillings are, where your drillings are. So very, very rare that you can see where you put the implant. And here we put the implant. What you can see here is the apical part and the removed soft tissue, including the artificial material. And then we inserted our SIC tapered implant. And this is the insertion. And you can see, finally, we reached only a maximum of 20 Newton centimeter. This is not sufficient to make an immediate loading of the implant. This is a big problem. So we tried to do it with a tapered implant. It was a very aggressive tip. Finally, we choose the second one implant. We had to remove this tapered form. We used an SIC Max that is also armed with a reverse thread here on this side. And then you have a double point fixation here in the alveolar part and also in the apical part. And finally, when you do the curve, you can see, put it correct in, you end up with almost 35 Newton centimeter primary stability. And this is what you need, minimum 35, sometimes 40 Newton centimeter to make an immediate loading. And you can see from this small cut here, the implant tip is grabbing also the bone sometimes, and then you cover a small amount of artificial bone on the surface here. It's bleeding quite good, and finally you can put on the crown as we expected. This is some clinical view. When you leave the implant instrument here inside, you can put all artificial bone to have a socket preservation also in the crestal part, and the soft tissue. I made a small palatal cut here, what you can see here, and so it's possible to have an overextended soft tissue gingiva in a very good quality. And here is minimum 20 Newton centimeter, and here you can see it's a PRP or PRGF from Anitra, from the Endoret system, and at the end you come up like this. What I highly recommend is to retract, to avoid the retraction of the soft tissue here. You make some resin points here. You put it here, light curved resin, and you can make some stitches here to retract the soft tissue to the coronal part of the crown. And when you do so, here you can see this is also the PRP. You leave it there like it is. It gives you very good support and a soft shell over the implant. And this is the radiological after the implantation using the implant. And this is 2 weeks post-operatively. And here you can see the lateral part of the lateral incisor root resection, here the root resection of the central incisor, and here Teflon or P, special kind of Teflon stitches. They like the soft tissue, and this is 3 months after the final restoration. So what it shows, even when you go to avoid any mistake that can happen, you have to be a small, you have to go back, have an amount of implant, a range of implant of different rescue implants in your portfolio, and then you end up to avoid the complication. So settle on difficulties, say Confucius Master Kong, and you keep 100 away. So the more problems you can expect, the less you have to correct into the operation. So this is one of the intraoperative complications. I will come up to post-operative complications. This is a young lady, 75 years old at that time. I did this operation in 2004. You know, template implantation using templates was just rising, and we started with this very first case. I put in the implants. Well, you know, it is very easy. It's called implant in an hour, teeth in an hour concept. I think on Noble Biocast, big advertisements. She had a low bone level up to 0.99 centimeters in the interior part. And we decided to have a minimal invasive implantation. It's all guided surgery. Everybody knows this is very old, it's almost 15 years old. And put the implant through the soft tissue. And maybe the more experienced or the less experienced of you can see this can sometimes cause some problems when you keep in mind that the soft tissue is not in a very good condition here. So, operation, bar construction. 15 minutes later, insertion of the implant bar construction. And 5 years later, we had a loss of 2 implants. This is because of periimplantitis by guided surgery. How can you solve these late complications? Loss of construction and implants. You have to insert new implants, make sure that the bone is not fractured. Then you make a soft tissue correction. And then you end up, now it's almost 9 years later or 8 years later. I end up with Henry Ford, who says the greatest things in life is experience. and even mistakes have values. And this is the reason why I do the lecture today. That means when you want to have implantology and prosthetics, and you do it by your own, you're allowed to have a backward planning. That means prosthetics and implantology, you already have the prosthetic when you start with the implantology. Next case, this is a very case in 2018. I was thinking about the right implant in the right bone, and there are some possibilities to avoid early complications when you plan immediate loading. This is almost 60 years old patient with big problems with periodontal disease, and he said he wanted to remove all the teeth, and he wanted to end up with a very good prosthesis or a bridge. And I said, look, when we want to decide, you have different parts of the bone. You have D1, D2, up to D4, or reconstructed bone. Maybe there's a possibility to find the right implant diameter, but also the right design of the implant. And the Hounsfield unit gives you some chances to have an osteodensitometric implant selection. What you see in the lower left is when you put in the implant like this, you have a very good quality of D2 or D3 bone. When you change the design, the macro design of the implant, sometimes you will have different compression in the bone, and the artificial intelligence now in the systems gives you some support to find the right implant. So what is the right implant for my bone? It's not which company is selling the right implant for me and makes good condition. It's the other way around. So what is the best implant for the patient, and not for me, not for Straumann, not for SIC, for Nobel, for whoever, for Megagen? What is the right implant for the patient? And how is a digital concept to put these immediate prosthetic loading on these implants? Now we are on the way that we have the big companies who sell all the prosthetic components to have digital planning and to have guided surgery. The small companies sometimes do not have the right components to do this. So it's your decision. It's not only having the right implant, it's also having the right construction, supra construction on these implants. And finally, the question is how accurate, how precise is the prefabricated prosthetic? Is it okay? Is it not okay? This is a very extended case. I think it's 10 or 11 or maybe 9 implants. We try to have an implantation and an immediate loading on all these implants. This is the planning. There is a literature, it's called accuracy of densitometry of 2 cone beam computer tomography equipments in comparison with computer tomography. And this is the prefabricated bridge before implantation. This is navigational, the implant guide. And here you can see we have different types of implants. In the lower jaw, we used tapered implants. Normally, the bone in the lower jaw is very, very hard. But here we decided to have tapered forms. Normally, you have parallel implants. The threads are not very sharp. And in the upper jaw, sometimes we have tapered, but also maxillary implants with crestal compression. This is a result. But what you can see as well is that we have had problems with our superstructure. Here, this is good, is a good fit of the bridge, but here it's not in a correct way. So when you do so, when you make a bridge on 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 implants, the accuracy of the digital planning in 2008, maybe it's in 2020 is different, but in 2018, it was not sufficient to make an immediate loading only with digital planning. So we decided to have a new analog impression taking, and finally we inserted some more implants, and we ended up with the correct bridge construction over the maxilla. And in the lower jaw, the 3 implants here, the lower jaw, that works quite good. 3 implants, maybe 4 is okay, but 5 or more, that is very bad, even when you have only a teethless maxillary situation where you only have soft tissue. Charles de Gaulle said, you have to set simple goals, then you can take complicated deviations or detours. Vous devez fixer des objectifs simples, vous pouvez faire des détours compliqués. C'est ça. And now we go to case 5, prosthetic complications. Sometimes you have young patients like this one. You say, well, look, I have a son now, and I want to avoid that he's looking at me with a prosthesis, with a removable prosthesis. We said to him, it's no problem. We can put in some implants, and we make an immediate loading on these implants. It's a fix on 6 concept, like this, and we inserted his removable cover denture immediately, but finally we ended up with a prosthetic problem, as you can see here. So it's not directly like here on the right side. Here we are in the right axis, but on the left side we are just in the in the part between 2 teeth. And normally we had to remove the crown here a little bit because the abutment was too long. So we had to reduce the height of the prosthetic, or the bridge in this case, and it makes it visible. So this is prosthetic failure because your planning was bad. You had to insert the implant minimum 2 millimeters more on the bone, or take a shorter implant and in a little more to the distal part. Failure, prosthetic failure. Sometimes you have young ladies like this with a frontal implant. This tooth 1-1 was angulated and also had root resection. He was a little bit moving compared to the lateral incisor 2-1, and she wanted to have an implant. And normally I ask in this situation, is it an easy case or is it a very hard case? Normally you say it's the Legion of the Kings or Champions League. When you put in the frontal implant, you have to decide, is it a screwed or is it only a fixed passive fit? Is it a passive fit without abutments? We decided to make an implantation after extraction and an immediate loading. And normally when I do so, I use the natural crown. I remove a little bit of the inner parts and I refix it again. And here you can see the final after the operation, immediately after the operation. Here also my Teflon stitches, as I've shown in case number 2. And then you say to the patient, look, we have a good quality of bone there, but do not hit it because we need 3 months minimum to make sure that you have a very good integration. This is easy going normally, you could say. But finally, impression taking, and this is the before situation, angulated crown, and this is after. But you have to keep in mind that you have to talk about this one here, the lower one, the lower incisal, we call it 4-1 or 4-2. This is always moving. When this is angulated here, this is always moving. So you have to talk to the patient. Is it possible to remove it to the lingual part and make orthodontic treatment, for example? You have to talk to the patient. When you do the crown on the implant, sometimes it's too late. You cannot talk about this, and the people say, well, you did not very good patient education. Finally, she decided to have it in this way, and she was quite fine. But sometimes you have patient, this is a late complication, prosthetic, more broken, as you can see here. You have some cuts here, twice broken or 4 times broken. These patients sometimes ask you, is there any possibility to have a different concept of prosthetic? And then you have to decide maybe what is possible. When you look at the X-ray, that one, the doctors who treated her before knew
very good about the last reserve of the bone, the rest of the bone. They used a single piece implant with a button only. It is an easy way. Normally, you can see the axis is very bad. You can say, well, you can remove, you make a LIFO-1 osteotomy to have a very good condition. You can bone augmentation. You can make a sinus lifting to have a lateral part. But in this situation, what do you recommend? Different prosthetic concepts only on one button is very, very hard. And maybe trinia is one possibility, and the bar construction. I said to her, maybe possible improvements might be by a cemented bar. It's a very light material, a trinia material or bridge, or explantation covered denture, a short cantilever sometimes, or LIFO-1 osteotomy, but it's a very big surgery, or explantation and augmentation. And now I come to one part of complications about augmentation. You have to talk about augmentation before implantology. The patient in Germany or in Europe ask about, is there a possibility to make a reconstructive implantology? You can see here, reconstructive implantology means you reconstruct not only the implant and the tooth, you reconstruct also the bone. And then you can say, look, I give you the bone, and but what is the right way to augment? When you see the literature and you see the clinical outcome, this is Stand 2018, there is no clinical evidence according to the method or membrane technique, materials of membrane, bone quality. Well, distraction, when you do distraction osteotomy, there is a better bone quality, Esposito 2009. And when you extract the tooth and make a socket preservation, you have less failure rate. This is also made by Horvath and colleagues. And about the dimension stability, you can also assume the bigger the defect, the bigger the resorption. And when you do onlay osteoplasty, sometimes it's going very, very hard, up to 40–50%. Or you have experience. In our clinic, you have to ask, what is the patient, sorry, this is in German, what is the wish of the patient? What is possible for a lab technician, and what can you do? And the only thing, this is a summary of a case where I can show different possibilities. So I had a patient with different former implants in this case here, and I said, look, you need tooth extraction in the front, you need implantation and bone augmentation in the front, you need onlay plasty on the lower right side, and you need interpositioning and hip graft interpositioning on the lower right side. And so we did it, and we started with a special technique called ring bone technique. And let me see. This is a situation before. As you can see, 3rd degree. You can remove sometimes these teeth only with a pincet. That one too. Oh, short. Finally, you have a good soft tissue quality, except to one, the left lateral incisor. But it's possible to have this implantation done. Here you can see these are ceramic abutments. This is not bone. This is ceramic abutment here and here. In this case, the lateral left incisor, it was not possible to make an implantation. We only put in some bone. And finally, this is ring technique with an allergen bone from Botes, and this is a ring technique by hip graft or by the lower mandible. And you can insert the implant, and then you can see how good this is the tooth. And half a year later, you can see when you use the ring bone technique, there is a very good inserted implant here, and this is a bone in a very good quality. And finally, you end up with some prosthetic steps, impression taking, ceramic abutments, and
compared to the situation before, the final restoration was quite good for the patient. And when we talk about final restoration in Germany, it means also to have some lip done, some hyaluronic acid. This is the tip on the eye when the patients come to me to the aesthetic education. So finally, it is up to you which implantation form and augmentation form you use. Yeah. So this is when we compare. So we made a small comparison. 3 years bone dimension. We figured out when you have a bone builder or 3D or a ring bone technique or a tibia plate for reconstruction or the hip graft. Sorry, this is bone builder, tibia cortical plate. You can see on the right side here, and the hip graft is the last one. They are almost comparable. So it's up to you if you decide to buy some materials or to get it from the patient. Case 9. I have 10 case reports, and the last 2 case reports are a little bit more complicated. This is a patient who came to us, almost middle-aged, 55 years old lady, and she had this situation. And we said to her, okay, this is very bad because the final restoration was like this, not good. And she came like this. And we said to her, well, it's possible to make a sinus lifting on the right side to insert some implant, and then you can have a bar construction, or you can have a non-removable, a fixed prosthesis or a bridge. And we finally ended up with a prosthetic long-time provisional bridge. And we had this final situation based on 6 implants. We had to remove the central incisors. And I will make this very short. This is sinus lifting both sides, 6 implants in the upper jaw, and before inserted the bridge on the left side and on the right side. And the clinical picture is like this, the clinical situation. Again, the X-ray and the lower jaw as well. So full mouth rehabilitation and 3 months of adjustment. She came to our office. She wanted to have different lengths of the teeth of the central incisors. The palatal crown was too big. She suffered because the tongue was not in the right way. So finally, maybe you can recognize where the problem is. Finally, we got some help because the patient was suing us to the court because of non-sufficiently informed about the lateral augmentation. The thing was her tongue was hurt by this implant in this situation. And the lawyer said as well, well, the bridges in the lower jaw are not quite good, they are bad, whatever. Finally, she did not win the court. But after having all this experience and augmentation, this is before she came with this situation, with this very big sagittal deficit, and we made this on the right side, but the patient still was unhappy, and she got to the court. So what is very interesting, you have to do the communication, and you have to deal sometimes with failures because the patient's expectations are different, and sometimes you do not explain the right way. So you look from the doctor's side, and the patient look from the patient's side. The perspective makes the difference sometimes. Is it a 9 or is it a 6? And I did some courses for some colleagues here in Germany. There are different models how to communicate and how to deal with failures. One is a very old one. It's called the iceberg model from Sigmund Freud. Maybe most of you know this. That means 80% is unconscious and 20% of what you talk, 80% is non-conscious and 20% is unconscious. And the second model is from It's called the 4-ear model. It means in medical communication, when you talk to your patient, normally you are not sending the informations, you have to get the information. So the patient sends you information and you are the recipient. And there is also one model for communication. It's called the 5 pragmatic axioms. That means you cannot not communicate. So when you go to the patient and you say nothing, this is even communication. So there is some literature here you can see above. And this is your expectation of the weekend. Flying to Paris, maybe not in COVID times. And this is the reality. And I have one patient, he is a famous singer, or he wanted to become a famous singer in Germany. He was coming to my office and said, look at my situation. He had a non-developed lateral incisor on the lower left side, and he was a little bit ugly, but anyhow, he was a nice guy. And I said to him, well, what we can do is we can remove the teeth, we can put in some implants, and then maybe it's possible to insert also a crown to make an immediate loading. And this is my vision. The doctor, I was sending this vision, as you can see on the left side, without orthodontic treatment, but the patient's vision was totally different. And I'll show you the picture that we got after 2 years of treatment. It's like this. Now he is a famous singer. He is the winner of the Jungle Camp. Maybe you know this TV format in the Australian bush. He is the king of the jungle now. And how can you achieve such things for patients? You have to put him on the chrono track. And the chrono track for the treatment in our clinic is, we have implantology, yes, we have prosthetics and smile design and facial harmony as well, but you have to do bone regeneration beforehand, or orthodontic or orthodontic. When you do so, you can get ortho patients like this, dental rehabilitation, class 3 format. This is a syndroma. We do osteotomy, lateral augmentation, LUFO 1 osteotomy, bone augmentation. He needs orthodontic treatments. You can use also the teeth to get the bone from the lateral, from the central incisors or from the canines backwards. If you move the tooth, the bone will follow you. And finally, you have a final restoration implantation and a full mouth rehabilitation. You can get the things when you put the patients on the chrono track. It's published with my colleagues at university. But when you deal with failures, you have to say clearly, say what is up and say what you cannot do. Say what makes sense, say what does not make any sense, and then you have to put the patient on the timeline. And when they say, look, we can get a very good result. You can get facial harmony and dental harmony and full mouth rehabilitation, but I need your support, shoulder to shoulder. This is what you need from the patient. This is the very first compliance test, especially here in Europe, where there are a lot of lawyers who want to judge you when you do any mistakes. A clear prediction is better than harmony with the patient. And if there is no harmony, don't treat the patient. Same, you're not the right one. In my clinic, we have a concept where all the conflicts and problems and expectations are written down. I said to my assistant, we need only one formula, one DNH4 formula where it's written all the complications, and we use it for every patient. There is also psychological impairments, problems, doing surgery again, and so on. So finally, you as a doctor, don't be super critical. Sometimes you are so dissatisfied with your work and you don't like it, but the patient says, well, it looks great, even if it's gray or yellow colored teeth. And the summary, and now we'll come to the end, it's almost 45 minutes. I showed you 10 case reports, different parts of implantation, augmentation, and communication. I talked about 30 hours patient education. That means in 10 case reports, 3 hours minimum education patient, showing different possibilities. You need to write it down in your digital file or in your format of a patient report, and the reflection of one or less court or litigation. I showed you the chronological workflow, or the timeline, the chrono track. I showed you 2 flow charts, estimation, dimension of bone reconstruction. Sorry, this in Germany at that time was very late to make this lecture in English. And finally, the reflection on the most common mistakes, and to have a triangle. When you have operative mistakes and complication that you have to master, and go to Dr. Anas Damlaki, go to the Aleppo Syndicate, do your courses, international courses, and then you can go on with bleeding, bone necrosis, different implant positioning, mobile mucosa or treatment. But keep in mind, when you have to make a good planning, be sure that all the prosthetic components are available for your system. So that means immediate loading or implant fracture, cosmetic complications, and speech building for as well. You must and you should plan before to avoid any prosthetic complications. And finally, the patient-related complications, you should practice every day to find out the right patients. My former chief or my former chiefs said to me, look, 3 patients are coming to my office. I only will treat 1. 2 of them are not special for me. They can go elsewhere because I cannot give them what they want. This is from facial plastic surgery. I know maybe it's not implantology, but keep it in mind. Sometimes when there's a bad harmony, don't go with this patients. Otherwise, you have to go to the court, and sometimes you will be judged. And this is the final. I think. Thank you very much for your information. I hope you find some hints from my daily work, some overviews. And if you have any questions, you can reach me on niliusclinic.com or via Instagram, niliusclinic-Dortmund, or you go by email to Anas Damlaki, or you can find me